Afternoon, and thank you for joining us for our What We Know Now, an overview and update of CAR T-cell therapy webinar. My name is Victoria Tripp, and I'm an oncology social worker and community navigator for Cancer Support Community's CAR T Concierge program. I work alongside an amazing group of navigators and resource specialists on the helpline. We stand ready to assist patients, caregivers, and healthcare providers with emotional support and connection to resources. Dawn Eli is also assisting with today's session. Please send a message to our host using the Zoom chat if you experience any technical issues during the session. Before we begin, just a few housekeeping items. Today's webinar is being recorded and will be available for viewing after the event. All webinar attendees will receive an email with a link to the recording. If you'd like to ask a question during the presentation, please do so using the Q&A feature in Zoom. We will do our best to address all questions during the Q&A session at the end of the presentation. To turn on closed captions, please click the CC button in the Zoom toolbar. Now, I would like to introduce our two speakers today, Laurie Adami and Dr. Jacobson. Diagnosed with incurable stage 4 follicular non-Hodgkin's lymphoma at the age of 46 in 2006, Laurie spent 12 years in continuous cancer treatment. She had 7 different lines of therapy, including 3 clinical trials, but the first 6 therapies failed to produce complete remission. In 2018, as her 7th treatment, she received CAR T in a clinical trial and finally achieved a complete remission where she remains today. Laurie spends considerable time assisting cancer patients navigating the challenges a cancer diagnosis brings. She volunteers with Leukemia and Lymphoma Society, Lymphoma Research Foundation, and Cancer Research Institute. She is the most recent recipient of the de Villiers Family Legacy Award for her outstanding volunteer work with LLS. Since her successful CAR T treatment, Laurie has focused on improving her physical health and has enjoyed several physical challenges: the Los Angeles Marathon in 2021, summiting Mount Washington in 2021, the DC Marine Corps Marathon in 2022, and this year she'll climb Mount Whitney, and in June 2024, she'll join the LLS Climb to Cure Trek in Cotopaxi, Ecuador. Dr. Jacobson is an assistant professor of medicine at Harvard Medical School and a lymphoma clinical investigator at the Dana-Farber Cancer Institute. Her research interests involve the clinical and translational studies of CAR T cells and other cellular therapies for the treatment of lymphoma. She serves as the medical director of the Immune Effector Cell Therapy Program at Dana-Farber Cancer Institute, which oversees the commercial and research programs of engineered cellular therapies across hematologic malignancies and solid tumors. First, we will hear from Dr. Jacobson with an update on CAR T, and then Laurie will share her personal experience with the therapy. We'll then answer your submitted questions during the Q&A. So without further ado, please join me in welcoming Dr. Laurie, and I'll hand this over to Dr. Jacobson.
Great. Thanks so much, Victoria, and of course, Laurie, for all of your volunteer efforts and your participation today. So I'm going to spend the next 15, 20, maybe 25 minutes talking about what we know now with an overview and an update of CAR T-cell therapy. Make sure that I can advance. Okay, these are just my disclosures. So I'll start with a general overview of CAR T-cell therapy, really the what, why, how, and wow of CAR T-cells, and then review some recent findings and learnings in terms of the latest innovations and results that we've been seeing, and then taking a little bit of a step back and an appraisal of how we're doing. Obviously, there are ongoing logistical hurdles that we need to overcome in order to really reach more patients with this therapy. And then we'll end with a sneak preview for future directions and sort of the road ahead and where we're going. All right, so we will start with our general overview of CAR T-cell therapy. I just want to set the stage for why CAR T-cell therapy emerged as a treatment for cancer. So we know the immune system can be an effective tool in our fight against cancer cells. We know that the things like allogeneic stem cell transplant, where we actually replace the patient's immune system with that of a donor immune system, can seek out and eradicate relapsing cancer cells before they give rise to a full clinical relapse. But when we try to, there are a couple of pitfalls when we try to sort of use the patient's own immune system to treat a cancer. And some of that is because the cancer cells are too similar to the patient's normal cells, and the immune system has been trained not to attack the patient's own cells. And so they may not attack a cancer cell because it's too like the patient's normal cell. The other is that the immune cells within the tumor are often outnumbered, and that can lead to an inability to eradicate the cancer cells, as well as T cell exhaustion. And then the cancer cells themselves are able to inhibit T cells, even if they are there and present, mixed within the tumor and present in normal numbers. And so, these are three sort of roadblocks we have to sort of harnessing the immune system to treat cancer. And there are a number of ways that these roadblocks have been approached in order to try to overcome them. So there are drugs like checkpoint inhibitors, which can turn off the negative interactions between tumor cells or cells that are mixed with tumor cells in the microenvironment and the T cells, so that those T cells can become activated, hopefully, against the tumor. There are newer therapies such as bispecific antibodies, which are only now starting to be approved in a variety of diseases, where the antibodies bind to both the tumor cell and immune cells and bring them together to hopefully lead to an immune response. And then we come to CAR T cell therapy, where we actually take cells from the patient's T cells from the patient's own blood, and we genetically modify them so that they can express a receptor on the surface of the T cell that it allows the T cell to bind to and recognize and bind to the tumor cell. And then when it does that, it actually activates the T cell to kill the tumor cell that it's bound to, very much the same way a T cell would kill a cell that's infected by a virus. So that's really depicted here in this cartoon, where you have a normal T cell that then has been engineered to express these CAR T cells, which then allows them to recognize a cancer cell and kill the cancer cell the same way that it would a cell infected by a virus. And in doing so, that they also become more activated and expand and multiply to create a bigger army of these killer T cells in order to eradicate the tumor. So again, just to sort of put this, I think a picture speaks 1,000 words, just to really kind of drive this home. Again, we have the patient and we collect cells from their blood, immune cells from their blood called T cells. These T cells are then sent to a laboratory where they are injected, often using a virus to inject new DNA into the cell. That DNA makes its way to the nucleus, where it gets integrated and actually gets expressed. And then eventually a protein shows up on the surface of the cell that is the CAR, the chimeric antigen receptor. And the CAR really has three important parts. It has this part that sits outside the cell that has the specificity for the tumor. And then it has these two parts that are inside the cell that serve to activate the T cell when this part that's outside the cell binds to the tumor and tells it to turn these other two parts on. And that's really where the signaling comes to the T cell to say you should kill the cell that you're bound to. This process of growing up the cells and creating the CAR T, engineering them to create the CAR T cells, and then all the quality testing that has to ensue afterwards can take anywhere between about 17 days to as many as 35 days, depending on the product that we're talking about. And of course, all the while, the patient is sitting with their cancer, potentially growing, which can become sometimes a rate limiting factor. But when these cells are ready, they come back to the cancer center. The patient's then usually treated with 3 days, usually 3 days of chemotherapy that we call lymphodepleting chemotherapy. We usually use a drug called fludarabine and cyclophosphamide. This chemotherapy is really not meant to treat the underlying cancer, but it's really meant to make the patient a better host to receive the T cells, so that when they do receive the T cells are meeting sort of an environment in the bloodstream and in the body that's conducive to activation and expansion. And then, of course, we monitor patients for some of the side effects of CAR T cells, which we'll talk about in a couple of slides, and then finally for disease response. And we'll go through some of the excellent outcomes that we've seen with CAR T cells, and of course, Laurie will talk about her own experience. So I think it's important to, not right now, not all cancers have CAR T cells that have been successfully developed for them. And I think it's important to take a step back and think about what makes a cancer a good CAR T cell candidate. So the cancer has to have a protein or a target on its surface that's present on all or most of the cancer cells and is really necessary for that cancer cell to survive. Because if it wasn't present on all or most of the cancer cells, obviously then some cells might not be killed. And if it wasn't important for the cancer cell to survive, it would be easy for the cancer cell to lose that target and then evade the CAR T cell response. But that tumor target, that protein on the surface of the tumor cell, cannot be present on normal healthy cells, such that an immune response against those normal healthy cells would lead to an unacceptable toxicity. So for instance, there were CAR T cells that were developed against a protein called CEA, which is a protein that's present in colorectal cancer, but it's also present on the normal healthy cells of the intestines. And so when they did treat patients with this CAR T cell, they were seeing a tumor response, but they were also seeing patients really get an immune attack of the entire colon, leading to sort of unacceptable colitis and diarrhea and GI toxicity. So CD19 really emerged as the first good CAR T cell tumor target. It's a protein that's present on most B-cell malignancies, on almost all the cells within the B-cell malignancy, and it is necessary for the cancer cell to survive. It is present on normal healthy B cells as well, which are cells of our immune system, but we know that patients can live without normal healthy B cells because there are genetic syndromes where people are born without healthy B cells, and we can supplement B cell function by giving back intravenous antibodies, which are the proteins that B cells make, in order to protect us against infection. And so back in the late 2000s and early 2010s, there were 4 different CD19 CARs that were developed at 4 different academic institutions. One at the University of Pennsylvania that then was licensed to Novartis and became tisagenlecleucel, which is also referred to as Kymriah. Then there was another CAR that was developed at the National Cancer Institute, which was then licensed to Kite Pharma, which is a Gilead company, and became axicabtagene ciloleucel, or Yescarta. And then the group at Memorial Sloan Kettering and the group at the Fred Hutch Cancer Center both developed independently 2 different CD19 CAR T cells that then was licensed to a company called Juno, which is now part of BMS. And one of these eventually became lisocabtagene maraleucel, also known as Breyanzi. And so why does this all matter? And so the reason it matters is because of the success of these CAR T cells in a number of B-cell blood cancers. So the first CAR T cell that was approved for the treatment of any cancer was tisagenlecleucel, or Kymriah, based on the results of this study, the Eliana study, which was sponsored by Novartis. It treated 75 pediatric and young adult patients with relapsed and refractory B-cell acute lymphoblastic leukemia, which is a very fast-growing leukemia. And if it relapses after an allogeneic or donor stem cell transplant, or cannot get into remission to go to a stem cell transplant, it is usually a fatal diagnosis for these young children and adults. And with a single infusion of Kymriah, these patients achieved complete response rates 81% of the time. And more importantly than having many patients achieve a complete response is the fact that these responses were durable. So at 12 months, 50% of patients remained without relapse, which really did indicate a cure for these patients, because this disease usually would relapse earlier within this time frame. And I show this picture over here. This is a picture of Emily Whitehead, who was one of the patients that was treated on this study, and she has become a poster child and a spokesperson for the field. She was treated at a young age of about 5 on the study, and you can see here what she looked like at age 6 when she was 1 year cancer-free. There was a picture that was taken 8 years later. Now she's a teenager and has grown up and is leading a normal life. She actually got to speak at the FDA hearing for the consideration of approval of Kymriah for pediatric and young adult B-ALL. And I am happy to say she's in an ongoing remission now, several years later, even still. So this is why it matters. And so this study led to the first FDA approval of Kymriah or tisagenlecleucel for the relapsed refractory B-ALL. The next approvals came in an aggressive type of B-cell lymphoma called large B-cell lymphoma. And this was based on, there were actually 3 products that were FDA approved for large B-cell lymphoma, Kymriah, which had already been approved for B-cell ALL, as well as Yescarta, and then most recently Breyanzi. And so just to put this into context, what these CAR T cells were able to do was lead to complete responses, actually complete responses in about 50 to 60% of people. So this bar is reversed. I apologize for that. And responses in about 80% of patients. And this is significantly better than what historical controls had previously been able to achieve, where we only really saw responses to drugs in these very chemotherapy refractory and multiply relapsed patients about 20 to 30% of the time. And we only saw remissions from those other therapies fewer than 10% of patients. And again, just like with ALL, more than just having these incredible response rates was the fact that these responses were durable. And when we compare the overall survival of patients who were treated on the ZUMA-1 study of Yescarta in these multiply relapsed patients with large B-cell lymphoma, you can see that a significant proportion of patients are staying alive and without disease relapse years out, and much better than what was available for historical controls. And I did want to share this one case that of a patient we treated at Dana-Farber. Obviously, this was a patient who had not responded to any chemotherapy, had rapidly growing lymphoma, actually was quite sick and unable to get out of bed by the time that we got him to his CAR T cells. And with a single infusion of axicabtagene ciloleucel or Yescarta, you can see his PET scan at 1 month, which was a very good partial response. And I can tell you now, 2.5 years later, he remains in a complete response and with a normal functional status. I also want to say, not only can it lead to amazing responses, but it's also a therapy that can lead to getting people back to their lives, pretty quickly. And so this was another patient of ours that we treated here at Dana-Farber, who had her own business. She was a hairdresser, and she had, if she didn't get onto the trial, the ZUMA-1 trial of axicabtagene ciloleucel for relapsed refractory large B-cell lymphoma, the only thing that we had for her was to try to get her to an allogeneic stem cell transplant, where she would have by necessity had to have been out of work for an entire year, which would not have been sustainable for her since she owned her own business. So just before we were ready to take her to an allogeneic stem cell transplant, she ended up getting a spot on the ZUMA-1 clinical trial, got her CAR T cells, and 6 weeks later was actually able to get back to work. And she's now 5 years later and still actually maybe 6 years later and still in an ongoing remission, having only missed 6 weeks of work. So now we'll take a little bit of a detour and talk a little bit about the recent findings and learnings. So I think we'll hear a little bit more about this from Laurie, but one other thing, aside from the initial approvals in aggressive leukemias and lymphomas, CAR T cells have been given to patients with slower growing cancers like mantle cell lymphoma, follicular lymphoma, and marginal zone lymphoma, which are diseases which historically have not been considered curable outside of an allogeneic or donor stem cell transplant. And when given to all 3 of these diseases, mantle cell lymphoma, follicular lymphoma, and marginal zone lymphoma, we can see really incredible responses where responses are as high as complete responses are as high as 67% for mantle cell lymphoma and as high as 79% for follicular lymphoma. And these are like, and just as before, these responses are quite durable. You can see a high proportion of patients are maintaining responses for years following infusion. And so we need to follow patients longer to understand I think not if these are curing some of these patients, but just how many of these patients we might be curing and actually changing the natural history of this disease. And like I said, we'll hear about this from Laurie as soon as I'm done. And so, of course, as we've given CAR T cells to patients in the multiply relapse setting where they've really exhausted other treatment options, the question arose is, can CAR T cells be used earlier? And so there were 3 clinical trials that actually randomized patients to either CAR T cells or standard second-line chemotherapy for patients with high-risk relapsing large B-cell lymphoma. So these are specifically patients who either didn't respond to first-line treatment or relapsed early after that frontline treatment. And the answer to the question is yes. Both the ZUMA-7 clinical trial and the TRANSFORM clinical trial were positive studies favoring CAR T cells over standard second-line chemotherapy for these patients. So the ZUMA-7 study looked at Yescarta or axicabtagene ciloleucel, whereas the TRANSFORM study looked at lisocabtagene maraleucel or Breyanzi. Unfortunately, the Belinda study, which looked at tisagen laclusol or Kymriah, was a negative study. So only axi-cel or Yescarta and Breyanzi or Lysocell were FDA approved for the second-line treatment of these high-risk relapsing large B-cell lymphoma patients. So, just to review, we now have actually 5 different FDA-approved CAR T-cell therapies for the treatment of B-cell malignancies, both acute lymphoblastic leukemia and other B-cell lymphomas, as well as multiple myeloma. The target in multiple myeloma is a different target than CD19. It's BCMA targeted therapy, and I unfortunately just don't have enough time today to go into the details about those approvals. And we're also seeing CAR T cells approved in earlier lines of therapy for some of the diseases like large B-cell lymphoma that had been approved, that had received approval in the more advanced setting years before. So let's take a look now and do a critical appraisal about how we are doing with CAR T cells. So I think it's important to sort of take a moment to think about the CAR T cell patient journey, because it is a more complicated therapy. Obviously, it does require referral to a tertiary center that is specialized in delivery of CAR T cell therapy. And then even at the CAR T cell treatment center, this involves collection of a patient's T cells, shipment of those cells to a third party, receipt of those cells back, and then administration to the patient, and then both short-term and long-term monitoring. And of course, because this collection, the time between collection and treatment can often be several weeks, and these patients have actively growing cancers, those patients require close monitoring and possibly the use of bridging therapies to control their disease, to keep the patient healthy enough to receive their CAR T cells on the other end. And so what I wanted to highlight here is that the points in yellow were really the points where I think the referring physicians and practices need to, that's where communication between them and the CAR T cell treatment center is vital. And then everything that's in blue or orange is really what happens within the CAR T cell treatment center. And so the first step is obviously identifying patients who should be referred. And my rule of thumb is that every patient who meets the FDA label should be referred, because there really is no age cutoff that's too old to receive CAR T cells. There's no requirement that the target be present on the CAR T on the tumor cell surface. All CAR T cell centers will have variable eligibility, and so I think it's really best to refer the patients and let the CAR T cell treatment center and the patient decide if this is the right therapy for them. It's really important to know that people who are not auto transplant candidates, which is high dose chemotherapy with autologous stem cell rescue, can be CAR T cell candidates, and so those patients should be referred. And we also know that treating patients as early as we possibly can when they have the least amount of disease leads to the best outcomes and lower toxicities. And so the earlier the referral, the better. And like I said, everything that then happens from eligibility evaluation to T cell collection to infusion of the CAR T cells, and the acute post-CAR monitoring happens at the CAR T cell treatment center. But again, another important touch point between the referring community and the CAR T cell treatment center is in the monitoring of the patient during the T cell manufacturing and the decisions to give the patient bridging therapy if needed. And then at the end of the acute post-CAR monitoring period, that's when patients will return. What marks that is really 4 weeks following the CAR T cell infusion. The patients will often then go back to their community where they will undergo long-term post-CAR monitoring. So in terms of just sort of focusing on those 3 yellow touch points where it really is about an interaction between the community and the CAR T cell treatment center, we'll look at the first one in terms of best referral practices. Many of these we really just reviewed, but I think it's important to refer patients early to optimize patient outcomes, because patients with lower volume disease and who are less heavily pretreated will do better. The treating center can evaluate patients for eligibility, and then they'll arrange and coordinate insurance authorization, consent, screening, testing, and patient education prior to scheduling the T cell collection. It's really best to let the treating center decide on eligibility. And so if the patient meets the FDA label, patients should be referred, and then the treating center can make the call. There are some special considerations that will be center dependent and in terms of whether patients who have these other risk factors would be a candidate for CAR T cells, but these evolve with time, and we've definitely increased or broadened our eligibility criteria as we've gotten better and better at administering these therapies to patients. So there are some toxicities you need to be aware of that happen in the first weeks following CAR T cell infusion related to their mechanism of action. The first is the cytokine release syndrome, which is related to activation of the T cells and release of inflammatory substances into the blood, which then activate other immune cells in the bloodstream, which then secrete further inflammatory substances. And the result is that patients can most commonly get a febrile flu-like illness, but this inflammation can escalate to potentially getting to a need for ICU level care. Thankfully, that's very rare because we can give patients inflammatory drugs to modulate this inflammation and generally keep patients out of the ICU. And this generally reverses within 3 to 5 days. This happens within generally 1 to 4 days following the CAR T cell infusion. The second toxicity is a neurologic toxicity related to some degree of inflammation of the brain that usually happens towards the tail end of cytokine release syndrome. This is more variable in terms of whether it will happen at all, how severe it will be, and how long it will happen, but it is a reversible toxicity that usually will reverse within days to weeks following its onset. And then once the patient clears the sort of the short-term toxicity window, again, which is usually around the first 4 weeks after CAR T cell infusion, there are some few and select sort of long-term toxicities that need to be monitored for either with help from the CAR T cell treatment center or once the patient goes back to the community. These include loss of B cell function because of the fact that these CAR T cells target healthy B cells as well. But as I said before, we can account for this by giving back intravenous immunoglobulins if those levels fall below a certain level. About a third of patients will have low blood counts for quite some time after CAR T cell therapy, and they may need close monitoring of those blood counts. The median time to recovery is 6 months, and so if patients do experience this, they need to have their blood counts monitored during that time to see if they need blood transfusions or injections of growth factors for their blood cells. And then because of the low blood counts, because of the B cell loss, and because of some of the effects of the conditioning chemotherapy for CAR T cells, patients are at increased risk for infection, greatest in the first few months and then followed by the first year after CAR T cell infusion. And so obviously we need to take any signs and symptoms of infection seriously. And so now we'll just end with a very, very brief discussion about where we're going and have a bit of a sneak preview about what's new for CAR T cells. So there is an attempt to move CAR T cells into the front line, and that is specifically in high-risk diffuse large B-cell lymphoma patients. It is based on, there was a phase 2 trial called the Zuma 12 trial, which actually already did this and took a cohort of about 40 patients with high risk diffuse large B-cell lymphoma who didn't respond favorably to 2 cycles of chemotherapy, and then collected T cells to make their CAR T cells with axi-cell. And when we look at the results for that study, it was very intriguing because patients did very, very well, very high complete response rate, even higher than what we saw when we gave CAR T cells to large B-cell lymphoma patients in the multiply relapse setting, and we saw very durable responses. And when we looked at the T cells that were made from those patients, they were actually more functional. So the idea was that if you could collect these T cells at an earlier point, you don't only benefit the patient by getting them to an effective therapy sooner, but you also benefit them by making an even more powerful T cell therapy. And so there is now an open and enrolling randomized study called the Zuma 23 study of Yescarta or axicabtagene ciloleucel, where high-risk large B-cell lymphoma patients will get 1 cycle of chemotherapy and then be randomized to either get axi-cell as their next therapy versus continue on to complete the entire 6 cycles of chemoimmunotherapy. And then I think we have to think about improving upon existing models. So not just moving things earlier, but actually can we make CARs safer? So there are different kinds of constructs that are being used to try to create more physiologic signaling and more specific signaling. So maybe you don't get quite the same cytokine release syndrome and neurologic toxicity. And then efforts to overcome mechanisms of resistance. So trying to avoid the CAR T cells from becoming exhausted, and so combining them with immune stimulatory drugs. There have been some patients that relapse after CAR T cells who have lost the tumor target. And so people are looking at combining 2 different tumor targets within the same CAR T cell, and those studies are ongoing. And then, as I mentioned before, with the Zuma 12 study, the T cells that were collected from the patients were much healthier. And so there are efforts underway to try to figure out how we can make the patient's T cells as healthy as possible before we use them to make their CAR T cells. And then, to speak to that, there is also work being done looking at alternative sources of these T cells. So can we actually collect these T cells from a donor, a healthy donor who doesn't have a cancer and hasn't seen cancer therapy, and use those to make the CAR T cells? And so those are underway, and the advantage of using these healthy donors is that A, the T cells will be healthier, B, you can make multiple products from one single patient, so it may actually end up being cheaper. And then the last advantage is, of course, that these are available frozen in your freezer, and so can be taken literally off the shelf for patients to be used. So there's no delay from when you identify somebody as a good CAR T cell candidate to their treatment. So I'm going to conclude here and just remind everybody that CAR T cells are really a revolutionary new form of immune therapy in which T cells are engineered to recognize and kill tumor cells. It's really a living drug. And following a single infusion of CD19 CAR T cells, nearly half of patients with refractory BALL and aggressive B-cell non-Hodgkin lymphoma will have durable years-long remission. But to deliver these therapies that have unique toxicities safely, a robust program with multidisciplinary staff is necessary. And only a fraction of eligible patients today are getting CAR T cells. And this is because of myths about challenges in eligibility. It's due to referral biases and geographic inconsistencies. And I think greater clinician and patient education is really vital to get this revolutionary therapy to more patients. And so with that, I'm going to end, and we're going to hear from Laurie, which is, I know what we're all waiting to hear from.
Thank you. It's my pleasure to be here with you today. Thank you to the cancer support community for sponsoring this event. And thank you, Dr. Jacobson, for all of your insights and the great work you do for patients. On July 16, 2018, I received my CAR T cells at UCLA in Los Angeles, one of 5 patients enrolled in the phase 2 Zuma 5 clinical trial that Dr. Jacobson had referred to earlier. I want to start my presentation by sharing an image with you that is very powerful and clearly illustrates the potential of CAR T. The image on the left you can see is dated July 9, 2018. This was 1 week before I got my CAR T cells back. The cancer was pretty much everywhere, even in my bone marrow. All of the black areas, except the blacked out area on the top of my head, are cancer. You couldn't really see my face because I had tumors that were puffing out everywhere. My oncologist estimated I had 8 pounds of tumor burden. I had a bulky tumor that was pressing on my right kidney, and I was in danger of having my kidney blocked. And we had attempted to debulk my disease before my CAR T infusion, but after my prior 6 lines of treatment, my disease was refractory to the debulking and just said, whatever, you can try to hit me with something, but I'm here. Looking to the image on the right, which was just 4 weeks after the infusion of my CAR T, my disease was gone. The only black spots on this images on the right are normal organ function. This summer, I will have my 5-year diagnostic scan and will hopefully receive the news that I continue to remain in a complete remission. Okay, you can take the image down. Thank you. I want to highlight some of the issues that are important for patients to consider as they look at CAR T as an option. I think the more a patient can learn about CAR T, the better. CAR T may be presented as one option, so one needs to consider the potential effectiveness of CAR T versus the effectiveness of other treatments, the potential for CAR T side effects versus side effects of other options, and the potential that CAR T could eliminate your disease for a very long time versus the potential for other treatments to do so. I also encourage patients to get additional opinions if one is being presented with multiple treatment options and if you have the opportunity to do so. Finding an expert in your diagnosis is very important. So for example, if you're diagnosed with lymphoma, please try to consult with a lymphoma specialist and not a general oncologist. CAR T was originally researched and made available in trials at National Cancer Institute designated cancer centers, which limited its availability. But it's now available at almost 200 locations across the US, as well as internationally. Assuming the patient decides to proceed with CAR T, ask who will help to set up the necessary appointments at the institution where you'll receive it. I was in a clinical trial, so I had a trial coordinator who held my hand and set up all my appointments for the imaging, biopsies, debulking, apheresis, lymphodepleting, and then CAR T infusion. Institutions administering CAR T will have resources to support you, but please ask for a point person, and if possible, just one person, not multiple, as it will greatly simplify scheduling. Patients, as Dr. Jacobson mentioned, have to understand there's a period of time, which can be several weeks, between the harvesting of the T cells via apheresis and the return of the finished CAR T cell product. For me, the waiting time was a bit of a challenge as my disease was growing rapidly. I was able to speak to other patients who had had CAR T ahead of me, and that gave me a lot of perspective. I also received the reassurance from my oncologist that my CAR T cell production was on schedule, which helped me to worry less during the waiting period. As far as getting approval for health insurance to cover CAR T, I was lucky in that I received my CAR T in a clinical trial, and so 100% of the expenses associated with my CAR T were completely covered. But my experience speaking to patients is that they are getting their CAR T covered, be it through Medicare or their PPO and HMO health insurance plans. Occasionally, I hear stories of patients initially being denied coverage for CAR T, but if the patient's oncologist or the institution where they're going to get CAR T reach out to the insurer, these denials have been reversed. So again, ask for help if you get into trouble. CAR T patients are required to have a caregiver for the first 30 days following the infusion of their CAR T cells. The caregiver should also be educated about the CAR T process and the potential side effects to watch out for. The caretaker is in the best position to notice when a patient has a personality change, which could indicate some neurotoxicity starting to happen, and can be very helpful in communicating with the medical team if symptoms begin to appear. I have spoken to patients who have had one patient as their caregiver, a partner, an adult child, a parent, a sibling, or a close friend. I've also spoken to patients who didn't have a single person who could cover the 30-day period, so they split the role and had different people take on various lengths of time. When I received my CAR-T, there was not as much understanding as there is today about treating the most frequently seen side effects, cytokine release syndrome and neurotoxicity. Going into CAR-T with a very large tumor burden, we guessed I might experience more severe side effects than if I had smaller disease. And unfortunately, that is what happened to me. But I got through it, and my case likely contributed to the knowledge used by science to learn how to better manage these side effects. When I talk to patients, they're sometimes fearful about CRS and neurotoxicity, but I try to reassure them that there has been a great deal of progress made on managing these side effects, and the incidence and severity have been greatly reduced from the early days. Thankfully, there are agents that can now be used either prophylactically or in response to a side effect. So for example, anti-seizure medications, a drug called tocilizumab, and steroids are used actively now. I certainly don't want to minimize the risk of side effects, but my experience recently with patients has been very good, and mostly they experience fevers starting between day 4 and 7, and then maybe a day or so of confusion. Oftentimes, this is harder for the caregiver to witness as they are sitting and watching the patient and maybe feeling helpless. Usually the patient won't remember going through these side effects, which I know was true in my own case. It was harder on my son and my husband to watch. 5 years ago, there wasn't much patient literature about CAR-T, so I relied on my oncologist and what I could find online to learn about it. Thankfully, since then, availability of patient-friendly information has greatly improved. Organizations like the Cancer Support Community, the Leukemia and Lymphoma Society, the Lymphoma Research Foundation, and other disease-specific nonprofits have CAR-T information available on their websites. The Cancer Support Community has a wonderful CAR-T patient and caregiver guide that provides CAR-T cell therapy basics, a step-by-step guide to CAR-T, and record-keeping documents. Please reach out to these organizations. They're there to help. Some health insurance companies will also provide literature and assistance. So again, please ask. And the medical center where you are receiving CAR-T will also have information they can share with you. And they oftentimes offer a boot camp for patients to outline all the processes and answer concerns. Many of the nonprofits I mentioned provide patient and caregiver support groups and can also facilitate connecting patients and caregivers directly with someone like me who has already received CAR-T and can be there as a sounding board and a source of support. Ask to be connected with a patient advocate if you think it would be helpful to you. Often when I speak to a patient, they will introduce me to their caregiver, and then as the journey moves forward, the caregiver will reach out directly to me with questions and concerns, wondering if what their loved one is experiencing is normal. There are private CAR-T patient groups on Facebook where patients can learn more about CAR-T and meet others on the road with or ahead of them. My only warning about using social media is that the participants in these groups are not usually doctors, and there can be inaccurate and false information posted, so one must be very cautious and always talk to their doctor. But you might meet people in these forums whose stories are similar to your own, and you can get hope and ideas from these patients. As far as the future of CAR-T, as a survivor, I am optimistic that science will continue to advance the effectiveness of CAR-T so that more patients can get the complete and durable response that I did. Hopefully, additional targets will be identified and new diseases treated. Just last year, 2 CAR-Ts were approved for multiple myeloma, and I read about CAR-T being trialed for numerous other solid tumor cancers and autoimmune diseases like lupus. As I mentioned, over the years, I have been a CAR-T patient advocate. I've seen steady improvement in side effect management, and in recent months, I am encountering more and more patients doing CAR-T outpatient, which is good in that it reduces the cost of the hospital stay and allows the patient a more normal and comfortable environment to go through the process. I recently supported an 84-year-old man who successfully received his CAR-T outpatient and is now in complete remission. When treated outpatient, the patient stays near the cancer center where they're receiving their CAR-T, and they go in every day to the outpatient facility for labs, vitals, neurochecks, etc. If a patient develops CRS or neuro symptoms, they can then be admitted. All of you on the call are clearly aware of CAR-T, or you wouldn't be here. But I think there are still too many patients and medical personnel who are unaware of CAR-T as a viable treatment option. If a patient is in treatment at a community oncology practice by a general oncologist who lacks blood cancer treatment knowledge, they may be unaware of CAR-T. Personally, I'd like to see more of an effort made to educate the broader patient population and medical personnel. In conclusion, I would hope as CAR-T is determined to be more effective and potentially less toxic than other treatments, it will move up in the lines of treatment and be used earlier. I know in my own case, if I could have received CAR-T earlier in my 12-year cancer journey, I would not have experienced the side effects I had with my earlier, more toxic treatments. For me, getting CAR-T as my 7th line of treatment was just in time, but how I wish I could have gotten it as my 2nd or 3rd line. Thank you again for giving me the opportunity to share my experience. I will now pass it back to our moderator, Victoria.
Thank you so much, Dr. Jacobson and Laurie, for that wonderful presentation. So much good information. We're really happy that you're able to join us. We now have some time for Q&A. So as a reminder, you can submit your questions in the Q&A box and we'll do our best to get to them. And as you do that, I'll start asking some questions. So first, a question for Dr. Jacobson. The person said, I was told that CAR-T for multiple myeloma has a risk of Parkinson's. Is that true?
Yeah, so thanks for the question. And again, I'm sorry there wasn't more time to go through some of the trials and approvals in multiple myeloma. This question is, so there were 2 CAR-T cells that were approved for multiple myeloma. One was idacaptogene viclucil, which goes by the trade name Abecma, and the other is ciltacabtagene autoleucel, which goes by the trade name Carvykti. And so this question is specific to Carvykti. So it is true that there is a unique neurologic toxicity that was seen with Carvykti. It has not been seen to the same extent with Abecma, where patients do develop Parkinsonian-like syndrome with tremor and motor rigidity. This can actually be a late toxicity, so patients can experience it weeks to months after their CAR T cell infusion. I would say it's a rare toxicity, and it's even rarer still to have it be irreversible. So there are patients who experience this toxicity, and generally it will get better with time. Occasionally it can be treated with things like corticosteroids and things like that, but only in rare cases is it truly sort of irreversible and doesn't get better with time.
Thank you. Just following that up quickly, could you speak to the process of weighing pros and cons when safety plays a role? Because I know that a lot of patients will hear about these severe side effects and not really know how to make decisions.
Yeah, I think that's a great point. And I think that it is the reason that CAR T cells were initially studied in patients who had really run out of other treatment options, where sort of the balance of risks and benefits tends to favor the benefits, right? Because they're, when you don't have other effective treatment options, you're willing to assume increased risk and increased toxicities in order to have a good outcome. And I think one of the benefits of that is, thankfully it was successful in those advanced settings, but it's allowed us to treat lots of patients in the advanced settings, as Laurie alluded to, for many, many years. And we've gotten much, much better at both predicting as well as managing these side effects. And so overall, I think most of us feel that the side effects we see with CAR T-cell therapy are ones that we're familiar with now. They're ones that we can mitigate so that they don't escalate to something more extreme. And they're ones that are reversible and we can get patients through. And so that's allowed us to now think about bringing this into earlier lines of therapy where, it's actually now maybe even a safer and less toxic approach to treating someone's cancer than the 6 other lines of therapy that Laurie received for her follicular lymphoma over the years. And so, I do think it's important to have an open conversation with your physician and with the care team about what some of the expected toxicities are. But it's also important to remember that what was described and seen back in 2010 when these products were first given to patients is not what we're seeing today in 2023. We've made a lot of progress and we can continue to make more progress, but I think it's important to get a current appraisal of what the risks are for these therapies.
Awesome, thank you so much. A question for Laurie. What did you learn from your CAR T and cancer experience?
So personally, I learned the importance of advocating for myself, learning as much as I could about my disease, the current treatments and those coming. This gave me hope and empowered me to feel less a victim and more in control of my outcome. I learned that the patient is the one with the most skin in the game and the most to lose. And so becoming as much of your own advocate as possible was very helpful to me. And if a patient cannot advocate for themselves, I think it's really important to find someone who can help you do so. A family member, a dear friend. So I would say that was my biggest takeaway. And obviously never give up hope.
Thank you so much. Another question, this one is for Dr. Jacobson. How long after salvage chemo concludes does one have their apheresis to harvest T cells?
Yep. And so there's no sort of right answer to this. I think generally speaking, we would like to see patients were, generally after salvage chemotherapy, we see this lowering of the blood counts temporarily. And then once those blood counts recover and any side effects from that chemotherapy has recovered is usually a reasonable time to harvest those T cells. So generally speaking, it's usually somewhere in that 2 to 3 week time frame. That is usually the time that we have between cycles of salvage therapy. There's one caveat to this, which is that there are certain drugs that can impair T cell function for quite some time, even months after their administration. And one of those drugs is a chemotherapy drug called bendamustine. So if we think a patient is going to be close to needing CAR T cell therapy, we really try to avoid bendamustine really within the preceding 6 to 12 months before CAR T cell collection, because we think it can impact the function of the T cells and therefore the outcomes.
Thank you. Another question for you, Dr. Jacobson. I hear that some CAR T treatments are being delivered to an outpatient setting, which we talked about briefly. Do you think this is a good idea?
So I do. I think it's a good idea. I think so. There are. I think there are some CAR T cells where the sort of risks of the toxicities are pretty high in terms of getting any grade cytokine release syndrome with fevers and flu-like symptoms, and so and they can happen very early. And so I think when you have a CAR T cell product that leads to sort of early and high rates of those febrile syndromes, it's very reasonable to consider giving those inpatient unless you have a very good mechanism to monitor patients in the outpatient setting and then bring them in quickly if they were to develop those symptoms. But there are other CAR T cells that actually have, about 25% of patients will not develop that cytokine release syndrome. And if they do, it's usually 4 or 5 days after the infusion. In the case of Carvykti, it's actually 6 days or 7 days after the infusion. And so for those products where nothing happens for the first 5 or 6 days, you can save someone, half of their hospitalization if you keep them outpatient and then only bring them in when they develop the symptoms. And so and in some cases, it's if they develop the symptoms. We have had some patients at our institution that have been able to stay outpatient the whole time. So I do think it is a good option for the right product and the right patient.
And Laurie, I don't know if you want to add to that at all from the patient perspective, from what you're hearing, what are some pros or cons to it being in the outpatient versus inpatient?
Well, I think, being in the hospital, there's a lot of cost associated with being in the hospital. And to the extent a patient may be on the hook for some of their costs, I think it's great to reduce that expense. But it's also very nice, and especially through COVID, where caregivers weren't necessarily allowed to stay with the patient. I mean, now that's changing, but it's really nice when I talk to patients and their caregivers are there. They're staying in an apartment nearby, so they can have meals made for them, and they can have a more normal sleep cycle. When you're in the hospital, you're woken up all night long for blood checks and vitals checks and whatnot. And when you're staying outpatient, it's really nice. You can get better sleep, I think. So people that I've talked to have been really happy. Nothing against the hospitals. They do a fabulous job. But, from just a quality of life perspective, it's been really great. And you are staying close enough. So if anything happens, and these patients I'm talking to, some made it all the way through without having to go in the hospital. Others checked in like day 5, they got a fever. They were kept overnight, to make sure grade 1 CRS didn't go into grade 2, 3, or 4, but then they were released back. So I think the quality of life during that 30-day follow-up is much easier on the patient.
Yeah, that's a really good point. A question for you, Laurie. How did you keep your spirits up during so many treatments?
Oh gosh, I didn't always. And I kind of I'd get very depressed at times. But I was diagnosed when my son was in kindergarten, and I didn't get rid of it until he just graduated from high school. And my son was a huge motivator for me. So thinking about that face and my husband having to tell him mommy had died kept me going. And I would learn more. I would find a new trial. I would be, okay, this is the one that's going to work. I'll be done with it. I don't know. I just dusted myself off, and I always went back with, I just have to keep hoping I'm going to finally get the one that works. And finally, CAR-T was it for me. So I don't know how I did it, but I think my son was a big part. My husband says, well, what about me? I said, you'll get another wife. A son can't get another parent. So I think that was a lot of what gave me the hope, and just the fact that medical science was advancing so rapidly, especially at the end of my cancer journey where CAR-T came and other things. I just had to keep getting hope back and just keep dusting myself off.
Thank you for that. I appreciate how honest you were in saying, you weren't always able to. You were depressed sometimes, and that's okay. I'm glad that you had support to keep you going. So thank you for sharing about that. Another question is, how can we find out about clinical trials that we might be a good fit for?
Can I answer that?
Go for it.
So there are organizations like the Leukemia and Lymphoma Society that actually offer services to patients to help you find clinical trials. So LLS has an 800 number you can call, and they have oncology nurses on staff who will take your diagnosis, take your treatment history, and within 48 hours will return to you a list of trials. And they have been incredibly helpful to patients I've been helping who maybe have relapsed after a treatment. There's also clinicaltrials.gov, which is a government website that will give you trials. But in my own experience, I found it to be a little less accurate and maybe out of, you find a lot of junk on that. Whereas if you go to LLS, you can even give them a geographic region to find trials. You can say, I just want to look in Massachusetts, or I want to look, nationally. So, so those are just a couple ideas.
Awesome. Thank you so much. We're at the end of our time, so thank you so much, Laurie and Dr. Jacobson, for being with us today. And thank you to our audience for joining us. Before we go, I just want to mention two things. We have a helpline. Thank you, Dawn, for putting that up for us. We have a CAR-T specific helpline. The number is there. So if there's any patients or caregivers or even health professionals who are wanting to learn more information or to be supported throughout their CAR-T journey, this is a great resource for you. I run this program and I'd be happy to support you through it. And then we also have our national helpline where patients can receive support. So feel free to call and reach us. We'd love to support you through your journey with cancer. As a reminder, all webinar attendees will receive an email with a link to the recording. Thank you again so much for joining us and enjoy the rest of your day.